how do we get this work done? So empowering others to act in Cotter's framework, step number 5. So translating this again to the practice team, really thinking about how do we identify clear roles on the team to get this work done, right? This can't be one person's job to do quality improvement in the practice. Oftentimes we found in our work, again, on the primary care side, that people are eager to take on improvement roles, but they need to have that role identified, delegated to them, recognized for it, and clarifying what is their role. In many practices I've worked with, there is the designation of a practice medical director, but there's no description of what that role means, right, or what their responsibilities are. There may or may not be clear designation of a quality improvement manager or director, or even I found in some practices that the title quality improvement champion. So really thinking about how are those roles identified, how do you use everybody up to the highest level of their capacity again, whether it's a medical assistant who might be able to have a role managing a registry, right, a population health registry, or periodically reviewing for quality improvement results, or managing the data wall in a practice, and really getting a lot of satisfaction from that designation and from that role. But just assuming that somebody's going to do it right, or just that one person is going to do it, is not going to work. Additionally, in terms of this notion of assigned roles, and I mentioned a few slides ago the notion of leadership for change. So really thinking about the importance of defined leadership roles in the practice, be they at the organization or at the practice level, and again, not making the assumption that people are born leaders, right? So I mentioned the good fortune that you might have in working with some practices that have a highly developed practice administrator and a clinician leader, that important dyad. You're lucky when you find that, right? So who are the folks that have those roles in the practice, and what are their leadership skills, and what can be done to really help develop those? You know, I like to say I must have missed the class in medical school about being an effective leader. It really was not taught in my era. I'm not sure now. It may be more embedded into a medical school curriculum, but we can't just assume that clinical leaders, whether they're the practice manager, the nurse manager, the QI manager, or the medical director, right, necessarily has those skills, and really need to think about, well, what do we need? We need people who can understand the task, who can really use data effectively to help provide feedback, let data speak the truth and point the way, right, and who really have that level 5 leadership described by Jim Collins in his writings about leadership, that really have that resolve combined with humility, and understand that they're trying to work on something that, I love this line, that are dedicated, where they're dedicated to a future they may not inhabit, right? So that they're committed to making changes in the practice that are going to support the big picture. And that, again, is just not always something we find. So having the ability in your work with practices to either find those people, or if they're in a role and maybe don't have some of these skills, the ability to name the vision, to the power, right, to legitimize the change, to be able to both, this one might be a sensitive one, public and private roles, given the last debate discussion, but we'll stay away from that. But to really be able to meet privately with individuals and support the change, right? You can't have a medical director who says, you know, in one meeting, okay, we're going to adopt this EMR, and then in the meeting with providers, gosh, I hate this EMR, how we can ever do that, right? So we're going to find that, and how do we work with those folks? How do we really help either identify that maybe their role isn't clear, maybe they're not the right person for the role, and or find ways to mentor them and work within the practice to try to cultivate those leadership skills, because without that leadership, getting a practice to successfully adopt a culture of quality improvement is darn right difficult, if not impossible. So if we keep going here along the framework of the 8 steps, so we talked about identifying effective leaders, and then planning for and creating short-term wins. So what priorities, right? Instead of tackling the biggest, most difficult problem in the practice, what can we identify and work with the practice to identify as things that are both important, urgent, and achievable, really trying to create short-term wins to give them confidence that they can do this work while collecting and sharing data to track the improvement, showing them, right, that what the change is, how we know it's a change, and how we know it's an improvement, the model for improvement, and really trying to be very explicit about a specific quality improvement approach and methods. You can see some of the ones, the sort of classic ones listed here: PDSA cycles, process improvement methodology, Lean, doing workflow process mapping, Six Sigma, total quality management. There are different tools that can be helpful in different situations. I think to many extent, and many times it doesn't necessarily matter which one, but having a methodology is critical, and following that in order to be able to have a structure for this improvement and to be able to identify a system for collecting data that can then be used for feedback. So thinking for a minute about some of the key ideas in terms of collecting data and then being able to use data transparently within the practice. Some key ideas. Leadership has to commitment to and confidence in using data to drive improvement, right? We're in clinical settings, we're working with clinicians who are at their core scientists. We've got to be able to find and use data and then share it in a transparent way and in a way that feels relevant to the clinicians and the clinical teams. There's nothing more motivating to providers than feeling like they have opportunities to improve, right? Nobody went to medical school to be last in the performance ranking. So looking for opportunities to do that in a safe way, a way where there's an environment where there's trust in the practice, and then a real commitment to celebrate successes and really use that data to drive improvement, not to shame people, right, but to be able to look at best practices, bright spots, and to drive that sharing of ideas. Again, thinking of the different QI methodologies, whether it's PDSA, Lean, etc., but they share some similarities in terms of an organizational commitment to quality, focus on the customer. This one, very importantly, a focus on systems, not people, right? A common theme in effective quality improvement strategies, that this is not about individuals and errors, but really about systems that need to be redesigned to work better, and that work best when using a team-based approach that is data-driven and committed to this culture of continuous quality improvement. And then the last two steps on the Carter framework, trying to consolidate the changes and institutionalize changes. So moving from the small test of change, right, to really saying, how do we build this into the system moving forward so that we make sure we have ongoing systems for timely feedback and reporting, showing what is an improvement, having some system for data dashboards, I mentioned a data wall, and continually trying to reassess what's working, as well as what's working within the practice team culture, thinking about the use of surveys of staff, of patients, to get that feedback and really have a better sense of how things are going among the practice team as well.